Good afternoon, everyone. First off, in case all of you haven't heard about the updated uh, stats on the EALs, the EALs will be open for 2 weeks each. So each week your new EALs will open, and they will be open for 2 weeks, and you have those 2 weeks to complete them, and then get them up to your 100% after those 2 weeks. Then they will be locked out. Um, as far as the EAL, like freezing up on you, or telling you to come back in so much time, uh, what they're suggesting is that when you go back in, um, don't click through everything so fast. Make sure you're taking your time, because if you're clicking through it real fast, I guess the system reads that as you still need more time off or something like that. So that's why it extends that time. And especially if you get something wrong, then it thinks that you really need to review. So make sure you're taking your time and reading through those when you're coming back for that little review part, so that it'll let you keep going and get more percentage done. Um, as far as your quizzes and the tests that are in Canvas now, the ones that are out there published, they're going to be having access codes placed on them that I will release to you um, each Wednesday during lecture, so that you can take that quiz either Thursday or Friday. Um, and then the access code is going to be different for each quiz and test. So you'll have to get Wednesday's lecture and watch it or catch the video or something in order to get that access code. The JOMI accounts, there was question about where you go into it and you start watching a video and then it stops you and makes you want to ask you to log in. If you enter your school email address into the user ID, we were told that your password will automatically be populated. And what we were being told is that your password would be automatically populated into the JOMI. So you just have to enter that school email address in the user ID, and I believe press tab and go through, so then the password will automatically pop in, and then you can log in. So I believe that's all the updates I have for you right now. Of course, if you guys come across any problems, issues with Canvas or being able to log into something or whatever, bring it to our attention so that we can move it up the chain and get it figured out and fixed. Everything's kind of a work in progress at the moment. So let's jump back in here to chapter 21. Where we left off, we were talking about the different sutures, like the multi-filament, monofilament, how you get the different needles and things like that. How do you read your suture labels? A lot of you have already seen this in lab. I kind of showed you this on the sutures and the information you get off of the packaging. But now we want to jump into some of these suture techniques and ways that you can bring tissue together. You can approximate tissue. That's what what the bringing of tissue edges together is approximation. Or also in suturing, we're either trying to accomplish that approximation, or we're trying to accomplish tying off a vessel, like a blood vessel that's bleeding, whether it be a vein or an artery, something like that. We're trying to tie that off to either prevent bleeding or to stop bleeding. But some of our techniques that we use, what I've shown you guys mainly in lab, closing up on these procedures that we've been doing, the breast biopsies, the appendectomies, is a continuous suture, which is you place your first suture in, you tie a knot at that one end, and then you go back and forth with that suture until you get to the other end of the wound, and then you tie another knot there. Uh, the problem with the continuous suture line is that if anywhere along the line the suture breaks, then the entire wound can open up. Then you have, but the pro to the continuous is that it's a quicker closure because you're not having to stop and cut each time. So uh, each technique has its own pros and cons. The interrupted stitch, um, where it gives you a lot of strength in that area, where you're using your interrupted stitches, uh, which means if one of them breaks, then the whole wound isn't compromised. You're just going to have that one small opening, and the edges may still be close enough together to heal and keep that seal. Uh, but it is time consuming. It takes, you have to put one in, tie that one off, cut it, then reposition your needle on the needle holder, put another one in, tie that one off, rather than just keep going like you're continuous. Um, like I said, each technique has its own pros and cons. But some places where you'll see a continuous suture technique used is usually in that subcuticular, where we're going just underneath the dermis of the skin and the epidermis, right? And that subcuticular layer. That's what sometimes you'll hear them refer to. I need the subcu stitch or something like that. And they're doing a continuous under there, and it's just going to bring those skin edges together without you having to see the suture on top or poke holes in the skin with the needle, which leaves, can leave little scars, and you can definitely see where someone has been sutured sometimes. When doing the purse string, that is a continuous technique, right? I'm placing one and then continuing all the way through, and then finally tying off that knot at the very end to get it to sink down. Your locking sutures, what you're doing here is you're providing a little bit more tension and strength to your knot and to your suture line. And I'll show you guys kind of the technique in lab, but I'll kind of describe it here. What you do is while you're doing the continuous, when you come back through, you're just going to loop your needle. You're going to kind of make a loop out of the suture and then pass your needle back through it so that it kind of overlaps when you pull it taut. I'll show you guys this in lab, the locking technique, when we go to close on the appies for this week and next week. But sometimes, we use suture, to tie off things, and like it shows here, in retention sutures. Retention sutures is if, maybe the patient had a lot of swelling, something like that, and we can't bring those skin edges, we can't approx them completely adjacent to one another. And what we can do is we can put in larger sutures, usually like a number 2 nylon suture. We put in a little bit further back off of the incision line, and then run them across, and we can pull them a little bit tighter. But when we do that, we usually use what are called bolsters. We can use plastic or rubber. The plastic ones are ones that have been made by the manufacturers, but they go over the suture itself. Like you feed the suture through it. It's got a lumen to it. In the past, before the invention of the plastic ones, what we would do is we would take the straight caths, the Red Robinson catheters, and we would just cut them and just get we cut them into like thirds and just take the middle rubber tubing part and feed the suture through that. And those bolsters lay down over the top of the skin where you're putting the most tension on to protect the skin. And it cutting in when you're putting that much tension on the sutures to try and bring those skin edges together. You don't want that suture cutting through the skin, so that's why you use the bolsters. But we do the suture ligatures where we're tying off a blood vessel, and And then in orthopedics, there are anchoring devices into the bone, especially where you have areas that ligament, well, I guess where tendon attaches to bone, because the ligaments attached to muscle. So uh, where you have like a torn tendon or something like that, um, most Achilles ruptures happen in the middle of the tendon. So what you're doing there is you're suturing the tendon back together. But like in the shoulder, where you have like a rotator cuff tear or something like that, you have some tendinous tissue in there. You also have the labrum. That's a piece of little tendinous tissue that connects the glenoid, and you can have a kind of a tear away from there. And in orthopedics, what they do is they have like a little anchor. It's like a plastic. Um, for those of you who've ever hung up a picture or some curtains or something on like drywall and you didn't have the stud to go into, and you need to put that little plastic, you need to kind of drill out a hole first and then put that little plastic thing, then it'll hold the screw and doesn't just come out of the drywall. Um, it's kind of like that, where it's got the barbs to it. So it'll go in easy, but to try and pull it out, it's going to be stuck in there. And then off the ends of those comes your suture strings. They're actually attached to the anchor devices, and then you can feed it through the tissue that is torn away from that bone and cinch it back down to where it was supposed to be. It's pretty cool. A lot of it's done arthroscopically now, arthroscopic shoulder, rotator cuff repairs, things like that. Um, it's a pretty cool case to watch because you actually get to see it cinch down. You get to see those rotator cuffs, those tears get closed up and things like that. So they're actually pretty cool to watch. Now, something we need to really focus in on, because we are been talking about like sutures and things like that, and our we've been dealing with some of our sharps and stuff, uh, but we need to really hone in on prevention of needle stick injuries and what to do in the case of a needle stick injury. It can happen. I have been stuck once by a surgeon. It was kind of my fault. He had pulled he had passed the suture through and he was bringing it back and he was repositioning his needle on his needle holder. And I was going to take that opportunity to dab the field, which is you take a sponge and you just kind of wipe the blood off so they can see. And I just reacted a little too late, and he was already ready with his needle and was coming back in when I was heading into dab. We kind of met at the same time, and I got stuck. But the one of the best ways of preventing these needle stick injuries is just have a healthy respect for that sharp. Right? Know that it can cause injury, and don't be so afraid of it that you can't handle it, or you're like, I just don't want to. Just know that hey, that can do some damage. Let me be extra cautious here and be like, okay, I've got it. Make sure you're grabbing it and taking it from me. You're not looking off at something else while you're grabbing it, or looking away just as you're grabbing it. Things like that. Those are the things that are going to cause injury. Try not to be into that hurry. Right. That's why you always want your suture kind of already ready to go. You're not over there trying to load it up while they're going, come on, I need another one. Let's go. Hurry up. Patient's bleeding. You're already ready. Right. You want, like, as far as like, your safeties and stuff like that. Those are the things that are going to kind of get you through. Preventing loss of suture. The surgeons are going to kind of do this unconsciously because that's the way they were taught. Right. You don't take one big long piece of string and tie a knot in the middle of it and then cut it and waste the whole string. This is what you guys have been seeing me do when I do tying off vessels and things like that, like we've been doing the appies and stuff. I try to use the same tie on both ends of the vessel so that we're not wasting suture. Another way they're talking here about preventing that loss of suture is making sure your ends stay up on your sterile fields. Right, one hand is handling the needle holder, the other hand has a hold of the string as you're passing, so that you're not dipping below sterile level and dragging that up onto the field and then eventually into the patient, right? So, make sure we're using the right size needle for the right size, hole. We're not using this big giant, CT needle if we're working in a hole, 1 inch deep, right? That's too big of a needle. You have to really torque your body and your hand and everything to get it to feed in there, right? And then you may not be coming through right where you need to and things like that because the distance between the swedged on part of the suture and the point of the needle is so great, right? You don't need it that far apart. If there was a needle stick injury to happen, typically the person who got stuck immediately breaks scrub. That puncture site gets washed out of the scrub sink with the antibiotic soap. You can take a scrub brush too and scrub it out. Another thing you want to do is squeeze at that site, squeeze the blood out of it, because whatever went in is still localized kind of in that area. It has not reached your full bloodstream yet and gone systemic. So if you can, try to squeeze some of that out, right? Do not suck on it. Just squeeze it out and then wash it. And then you have to go down and do what are called PEPs, post-exposure prophylactics. That's where they'll put you on some like HIV medications, things like that, just to get you started on that. And then they're going to draw your blood, and they're also going to draw the blood of the patient and test them both for HIV, bloodborne pathogens, things like that, hepatitis B and stuff, and get you started already on medications before those test results come back. That's why it's post-exposure prophylactic. It's all just in case. And then if it comes back, negative for any bloodborne pathogen or whatever, then you don't have to continue taking those medications. But it's something to get you started on treatment right away. When you are at clinical, if by chance, it has happened to a few students, there is a needle stick injury, whether it is to you or to your patient. This meaning that if you accidentally stick yourself with a clean needle, that you do not let that needle get used on the patient. The proper protocol is the same as if you got stuck with a dirty needle. You have to break scrub. Go wash that site immediately. You don't have to get stuck on or put on any kind of prophylactic drugs or anything like that. You may have to get tested, because part of that testing is drug testing as well, because they want to make sure that you weren't like on some drugs or anything like that, and that impaired your decision making or your ability to do your job or something like that. But you'll still do that drug test, but you should still wash that site immediately, get that taken care of and everything before you continue to scrub that case. Get it properly dressed and taken care of, and all the paperwork and stuff filled out. There's a whole folder of paperwork, usually up at the front desk of any operating room department, on their needle stick injuries, with all the sheets and the incident and what happened and all that stuff filled out, and seeing employee health and all of that stuff. The other thing is, when you are on clinicals, if that were to happen, we need to be notified immediately. The first person I would notify if I were you would be Miss Kimbleton, because she'll be out there. She'll be the clinical coordinator. And then Mr. Ortiz. At a minimum, I would, if you're going to send out a text message or you're going to call one or the other, I would call Miss Kimbleton first, because she's the one that's going to come and immediately, be there to help you. But then you let Mr. Ortiz know in like a little text or whatever, but you also let him know that you have spoken with Miss Kimbleton and that she's en route or whatever. She's there to take care of it, that kind of thing. And the efficiency in passing your suture just comes from whatever hand you pick up that needle holder with is the hand you're going to give it to the surgeon with. You don't need to change hands. A lot of that's, that excess handling of these sharps is another thing that leads to these injuries and stuff. So you want to make sure that, your whatever hand you pick it up with, that's the hand you're giving it to them with. So whichever way you're going to pick it up, make sure you're picking it up. It's already properly in your hand to pass before you pick it up. That it's already ready for you to hand it to a right or left-handed doctor. And then remember, your opposite hand always has a hold of the end of that suture, just to make sure that it's not falling below sterile level. Right? When replacing your sutures after, let's say, a used one back into your needle book, they're not going to always use all of the string. Well, typically, what you want to do is you want to save that just in case they need it. This goes to part of that conservation, right? You're not opening, say, you started with a 27-inch long piece of suture on your needle, and they only used like 9 inches of it. And you still have an 18-inch long thing of suture, which is, that's 1.5 feet. I mean, it should be able to suture anything that they needed to. But when you put it back in your needle book, you immediately trimmed the excess suture that they didn't use off of that needle and put that in your trash bag. And then a couple minutes later, like, hey, you still have some of that 3/0 Vicryl? And you're like, oh no, I trimmed it. Now you have to open up a whole brand new one. That's a charge to the patient. When you could have just given that, and all they were going to do was put it in one more stitch. See? So, but it is good practice to trim the excess off of your needles. You just have to know when's a good time to do it. And some of that comes with experience. It's usually towards the end. You can see that, hey, we've gotten the appendix off. We've done our purse string and we've changed our gloves. And now, they're doing like a washout and stuff. We're going to start closing here in a minute. I probably should be able to trim the excess off of this chromic that wasn't used. Or if that chromic is in your dirty bin, then you don't have to worry about it. But see, that's one needle over there, not a whole bunch of them in your needle book with all these strings hanging off. That's why it's good practice to trim those strings. You just got to figure out when. Usually maybe during the time of counting. Just before you count, you hand them up that first stitch, and then make sure your strings are nice and neat. Something like that. Your suturing instruments, right? They always go together. Needle holder and a pair of pickups or forceps. Right? You have a needle on a needle holder, they're going to need a pair of forceps to manipulate that tissue that they're trying to suture. And immediately after you hand both of those up, the next instrument you should be grabbing is the straight mayos, right? Or suture scissors. Because whatever they're suturing, they're going to need to cut that string very soon. So you have them in your hand. If they have a first assist, you can hand them to the first assist. If the first assist is holding 2 retractors already, then you just hang on to them. And if the doctor wants them, they'll put their hand out. If they're ready for you to cut, they'll hold up both ends of the string and say, go ahead and cut me there. Leave a short tail or whatever. And you just slide down and do your cut. But, your smooth forceps, that's if we're dealing with delicate tissues, mucosal type tissues, right? Ovary, fallopian tube, intestine, appendix, stomach, liver, right? Spleen, kidney, right? A tooth forceps, something that's got those teeth on it, right? Like rat tooths or your Adsons with teeth, Bonnie forceps, those like that, they're meant to grab that heavier tissue, right? Skin, like connective type tissue, tendon, fascia, right, muscle. And then your vascular stuff that's meant to handle like your blood vessels, things like that. Those are your DeBakey's, Gerald's, things like that. They're a little smoother tipped. They have more of a vertical groove to them rather than those horizontal type groove. Um, and some of those vascular forceps can also be used on delicate mucosal type tissues and things like that. A lot of times they're preferred to because those smooth forceps, maybe they're not as long, maybe they don't grasp as well, those things, kind of things like that. And they're more used to those vascular, like the DeBakey's and things like that, and they're more trusted. So, a lot of you have practiced this, right? We've been working on this, passing, right? You want to grab that about half a millimeter. Who can look at a needle and know exactly where that half a millimeter is? That's why I told most of you guys, you see the rounded end of the needle at the end where the swedged on, where the suture's coming out of. Just beyond that rounded end, there's like kind of a flat spot, and that's where you want to grab your needle. That'll give you a good spot every time, right? You want that loose suture kind of over your hand. You're still holding onto it with that off hand when you're passing, making sure it stays on your sterile field. And then if you're passing for right-handed, right, you're trying to get that needle, the point of the needle, to hook them in the nose. And the same thing if you're left-handed, it's just the opposite side of the nose, right? You're trying to make sure that when you put it in their hand, that needle looks like it could poke them right on the side of their nose. And that's that position of use, right? Because they can take it immediately from you and go straight to the wound and start suturing. They don't have to adjust anything or turn it over or flip it around, any of that kind of stuff. These are some of your like considerations for how you position your needles, right? Obviously, right or left-handed, right? And considerations when you're passing, right? Is the surgeon across from you, right? Then you're putting it in that hand. Are they standing right next to you? Say you're right-handed and so are they, and they're standing right next to you. Well, now you've got to kind of, instead of that needle going out, you got to turn, right? Or you got to reach across and hand it to that hand and still put it in there the correct way for them to use it, right? And then there's also, I talked a lot to you about that backhanded, right? Some surgeons will ask for it to be loaded backhanded. Well, what they're doing is like in tennis, where you do like a backhand swing. That's how they're going to come at this suturing technique. Is they're going to come at it this backhanded, but they're still going to use their dominant hand. So if they're right-handed, you would load the suture like it's a left-handed doctor. And if they're left-handed, you would load it like they're right-handed, and that would be backhand for them. We can practice this more and more in the lab too. Passing multiple sutures. I talked about this too when we went over those sutures and stuff at the table in the lab. That if you have that control release pack, that you try to keep that nice and organized, right? You're putting the empties to one side while grabbing a new one from the back side of the continuation of the line of sutures that are lined up for you. What you want to do, if you're using a lot, back and forth, is for every one that you're going to give them, you want one back, so that there's always just one needle up on the field at any given time. It's not always going to work that way. Sometimes they put in what are called tag sutures, where they're going to, this will happen most often you'll see in craniotomies. When they go into the dura, they'll put a couple of some 4-0 nylons at the edges of the dura where they've cut into it, the edges of the flap to help hold them back. But they'll just take one of the straight hemostats and clamp it onto the suture and leave it there with the needle on it, because at the end, when they close it back up, they use those sutures to suture the dura shut, to reseal it back up. So They still need them for later, but they are serving a purpose. So those will be the times that the needle stays up in the field, and now you have to keep track of how many are up there. Make sure you're loading your needle before you remove it from the pack. Right, it's going to be the easiest. It's already set up in there for you to load it for a right-handed surgeon. Right? Your suture trash bag that'll hang off of your side. You can drop your suture packets in there, your empties, when you've used that suture or whatever. However, if there's ever a problem with the count, and this is not an official way, but if they ever want to see your suture packets to see how many sutures you had on the field or were supposed to have or something like that, you cannot reach into that bag and pull them back out because those are below your table level and considered to be unsterile. Any trash that goes in the bag stays in the bag. So I've seen a lot of techs who they save their suture packets on their field, on their back table. And it takes some time and some practice of loading, passing, and taking one back, putting it back, loading up another one, passing it, getting it back, putting it back, loading, to get the rhythm of it down and the technique of it down and being able to keep time and keep up. If at first you find it difficult, because what I typically do, once you get used to it, you'll have 2 needle holders. Right? One to pass, you give them that first one, they use it, hand it back to you, and then you're handing them the next one and then you take that one they hand it back to you, put it back in its pack, grab the next one. By the time you're grabbing that next one and pulling it out, they're finished with the second one you gave them. You're taking that needle back, handing them the new one next. It just takes some practice and some doing it over and over and over again to get the rhythm of it down and stuff like that. So, and we can practice that in the lab too. Right? When we start doing bowel resections, we'll do the suture anastomosis, and you'll see that we'll do like creation of colostomies and things like that. So you'll see that it comes quick, and so you gotta get that rhythm down. Ties on a pass, right? I've been having you guys do this for the appy, partly because I wanted you to practice it. The other part is we're going to come time here while we're doing the appy that I'm not going to be pulling that appendix outside of the patient. I'm going to be acting like it's stuck down inside, and we're going to need that tie on the passer. So it's always a good thing to practice over and over again so you can load these things up and get that suture right coming out of the tip with no extra. It's not as easy to do in the moment when the pressure is on and everyone's staring at you. So the more you can practice it now in lab, the better. These are your ligatures, or also known as a stick tie, because you got to stick the patient with the needle and tie it off. But this is how they would do a stick tie. And just kind of feed it through and then loop it around and then cinch it shut. It's kind of like the purse string, only you're just going to poke it through one time. But this is how we can use these to tie off blood vessels. Usually it's not, if you can see the blood vessel like this and it's completely, out on its own, you can see just the vessel, doesn't have any other tissue or anything stuck to it. They're going to use hemoclips, right? Those metal titanium clips that just clip right on there, and that'll do it. Usually the times you're going to be using these sutured ligatures is when the vessel has been like cut or damaged in some way and has retracted back into tissue. And they'll be using the forceps and just grabbing at the tissue and seeing, as they grab it and pinch it, when does the bleeding stop? Okay, when grabbing this bunch of tissue, I must have the vessel in here because the bleeding stopped, and they're just going to take the suture and put it throughout that tissue and then tighten it down and see if it still bleeds. That's what they're usually that's how you're usually going to see these stick ties and ligatures used now. When cutting suture, you need to use your straight mayos, right? Make sure you're holding the scissors correctly. You have your ring and your thumb, your ring finger and your thumb in the holes. You have your your middle finger resting just above the ring, up against the base of the scissor, and then your index finger is up near on the screw with the screw facing up, right? So that gives you that kind of stability. And then your pinky can be used to be placed down on the patient, or you can place your wrist down on the patient for stability. So you're not up in the air and your hand shaking. Trying to come in at the, always use the pinky, bring the pinky down, give some stability, and make your cut, or place your wrist down, or you can even hold your own hand with your other hand and come in and make your cut. What you want to do is you open just the tips of the scissors. In lab, it doesn't really work like this because our scissors aren't as sharp as you're going to find out in the real world. But you just open just the tips of the scissors. You put one edge up against the suture. You're going to slide that edge all the way down to the knot. You're going to feel it stop. Then you're going to turn the scissor either to about a 45 or 90-degree angle and then cut. That's going to leave just enough of the string hanging out the end of the knot so that the knot doesn't come untied, but not so much string that it becomes this irritable thing inside the body. And then those cut ends, or whatever cut end you take away and throw in your little trash bag hanging off your table. For suture removal, typically they're going to need a pair of scissors and a pair of pickups, and they're going to cut the suture that's in there and use the pickup to grab it by the knot and pull it out. And then you put up like a lap or a Raytech to collect the suture trash, the suture debris, and that keeps all of that from getting into the wound. Same reason why you take those cut ends away. You don't want those getting back into the wound, and because they would be a foreign substance to the body, and it would try to like wall it off and cause an abscess and all that kind of stuff. So implants, right? Some important terms about know about implants is an allograft means that it was human tissue, but it came from a different human than yourself. Because an autograft means that it came from your own personal self. So we can take pieces like when doing a coronary artery bypass, right? A CABG, or open heart surgery, right? We take the saphenous vein from the patient, from one of their legs, and use that as the graft, as the alternate pathway now. And we go across where the coronary artery is blocked. And what we do is we take a piece of that saphenous vein and hook it up to the artery where it's not blocked and blood is flowing into. And then we take the other end and hook it to a spot beyond the block. So then now it can still feed the muscle of the heart, and we don't have to do anything with the block. Bovine graft means that it came from beef or cows. Right? A porcine graft means that it came from a pig. Right? There's some porcine graft that they use in open hearts, and there's bovine graft that they use for vascular patches and things like that. So epithelialization. Remember, an epithelial cell is like that most outer layer of cells, right? Between any two layers of any object or any part of our body, right? That most outer layers are epithelial cells. When a wound is healing by secondary intention, where you just leave it open. That's that granulation type tissue you see out there where it looks all rocky and stuff like that. Those are epithelial cells growing over the top. And that's why scar tissue looks the way it does, because it's just a stack of epithelial cells. An implant is any like tissue or medical device or anything that is purposefully left in the patient as either for a replacement or to help keep something open, help keep something closed, all those kind of things. Your clips uh, technically are considered implants. We don't track them because they're just clamping off vessels that we've ligated and cut and stuff like that, and ducts and stuff that we've cut. But anything else from plates and screws in ortho and total joint implants, breast implants, mesh that gets put in for hernias, skin graft, taking a bone from like your iliac crest to be used in your wrist or something like that, or in your back. All of those are implants. And then wound covers. These are like what's the name of it? It's called a wound vac. If you're going to leave that patient open, there's this like black sponge that you can put in there, and then you put like clear sticky dressings over the top of it. You cut like a little tiny hole in that clear dressing, and then you put suction down over that little hole, and it sucks down that sponge so that any fluids or any like purulent oozings and things like that that wound is doing while it's healing get sucked up into that sponge and taken away into that suction to keep any of the dirty and blood pooling and stuff like that from happening that invites infection and microbes and stuff. And it also gives a covering to that wound, a nice airtight seal over it so that the surrounding microbes and things like that can't get into it as well until you can bring them back and close them later, or you can have it heal by that secondary intention. And then a xenograft would be both bovine and porcine, but also anything that's man-made, right? So it could be from an animal or a synthetic source as well, is the xenograft. But here's some of your types of tissue implants, right? Skin grafts, pig skin to put over for like burn patients, amniotic membranes, things that that we kind of engineer as like a skin substitute. The best thing for skin grafts is the patient's own skin. But one of the better things now for burn patients, they've been using like tilapia skins and things like that from fish. The fish oils and things like that come out of those, like the omegas and stuff, are really good for the healing of the skin, and not the scarring and stuff not to be as bad and stuff now. So, we're always on the lookout for new and better, right? You never know, 10 years, 15 years from now, it could be all new kind of stuff that we're doing. We may not even, be doing some of the traditional stuff that we've done in the past. As far as your bone graft, right? The autologous, this is from yourself. This is where you're, like I was talking about, you're taking a piece of the iliac crest and then moving it over into the wrist. You just take a little chunk out of the iliac crest. It'll grow back in the iliac crest, but you're replacing a bone in the wrist that got, either through arthritis or traumatic injury or something like this, got completely dusted. Then you have those allogenic. These are the human tissue that has been, like donated through science or, cadaver grafts, things like that. You can have ACL grafts this way, and tendon repair stuff this way, all kinds of, bone stuff. Uh, there's a lot of different types of implants and stuff like that out there now. You can have like these composite ones that are made up of different types of materials, not like, like you can have a ceramic and metal mix thing where part of it's ceramic, the other part's metal. Uh, you can have all ceramics. These would be more for your total joint implants. Um, umbilical cord sometimes get used as uh, implants for other things and stuff like that, because the vessels and things that are in them and stuff like that, you can use that as well. Um, all different kinds of, and all different types of techniques and reasons why we would need, these bone and stuff in other places and stuff. So, um, some of the synthetic implants used, for heart valves. You've got, your pacemakers, artificial joints, right? Defibrillators, things that go, into the patient. These are all like man-made uh, type items. They didn't come from. We didn't take like the nerves or something from another patient, like the SA and AV node, and are completely replacing somebody's SA and AV node. We have to put in a machine that's got like wires coming down out of it that we actually hook to the muscle wall of the heart to act as the new SA and AV nodes and make the pacemakers and stuff like that. So, um, in order to be able to use this human tissue or these implants or these composites, these synthetic things, we have to make sure that it's compatible with the body, right? Is the body going to completely reject it and wall it off and make this huge abscess out of it? Or is it going to be like, okay, we know you're not part of us, but you're kind of helping us out. You're not really doing us any harm, so we'll let you stay, right? Can we make it sterile? Because we're entering into body tissues, right? So it has to be sterile. It's a critical item, right? Is it big enough to cover what we need it to cover, right? Is it a big enough piece of tendon to deal with the injury that we have on this particular patient, right? Is it going to give us the right kind of stability and repair that we're looking for, right? If not, well, then why, there's no reason to use it. So the FDA are the ones who are in charge of implants. So remember that the FDA are the ones who are in charge of the implants and their medical testings and all of that that goes with those implants. The FDA is in charge of all implants, whether they be synthetic or natural. Some of your synthetic types, right? You got metal, methyl methacrylate, also known as bone cement. Methyl methacrylate is bone cement. It comes as a powder with also a little vial of liquid. You place the powder into your mixer, and then once you mix it with the fluid, then it turns into like this putty that will harden. It has an exothermic reaction, which means it gets hot. And it also kind of expands as it heats up, right? That's just kind of a natural basic science thing, right? As things heat up, they expand out. You've got some implants that are reabsorbable, right? When you're doing bunionectomies, and this is reshaping of the bone, the metatarsal uh, in the foot has just grown too long and kind of pushed up against the first bone in the phalange of the big toe and just kind of made them kind of tilt out, and that's why you see that big bump on the side of people's feet. It's not like some gross kind of thing or anything like that. But what has to happen is they have to reshape that metatarsal and that first phalange, and they have to cut out a piece of the bone and bring it back down so that you can get it back into alignment and take that bump out of the side of the foot. But because you cut out a piece of the bone, you got to bring those edges back together. and they'll put a screw in there. Uh, for the longest time, they were putting in a metal screw, and then after 6 to 8 weeks, when it's healed, then those patients, typically you don't have to have the screw. You don't have to have the screw removed. But if it starts to kind of back out or cause irritation or something like that to the patient, then you got to go back in and take that screw out. Well, someone came up with the idea of these bioabsorbable screws or reabsorbable implants. And now you put that in, and it's made out of the same stuff that Vicryl is made out of. And you just put that in, and over time, the body will absorb it. And so there shouldn't be any backing out or irritation or anything like that. The body will just absorb it, and you're good to go. Polyethylene, this is like a hard plastic. Usually you'll find it in total joints, they use it to put in the spacers between the metal implants. In your knee, what it basically acts like is your new meniscus. Your meniscus is that thin kind of cartilage piece that sits in between your femur and your tibia, so that when you're running or walking, you don't constantly have bone hitting against bone. It's that little cushion piece in there. So that's what the polyethylene is. But you can have ones that are made, you can have silicone implants when doing like total toe and total joint or total finger. Any place where you can bend, right? We can put a little implant in there. They have silicone ones. There were silicone implants for breast augmentations. They've gone away from that because the danger of rupture and the silicone poisoning that can come with that. And then you've got woven synthetics for making like vascular grafts, and you need them to be woven and stuff like that so that it provides that leak-proof ability. And woven just means that you've got one layer going, say diagonally northeast, then you put the next layer going northwest, and then a northeast again, and then back over the top of each other. So you kind of weave in and out so that if anything's trying to leak through, eventually you have a good seal. Drains. We're going to get into this too in the lab. We're going to be putting in drains and showing you. I'll pull out all the different kinds that we have in the lab. But you have what are called passive drains. And remember, guys, remember back to kind of your anatomy and physiology, and you had like the passive diffusion, right, where things are moving across a membrane due to like a concentration gradient, right? That was a passive thing. You didn't need the power of the cell to open up some channel and bring in specific minerals. The inside of the cell was just running low on certain minerals, and there was a lot of them on the outside. So it just, oh, hey, when they just kind of drained in to bring those levels back up. Anytime you think of passive, that's what's happening. It's just kind of using gravity as a drain. These are your Foley catheters. That is a passive drain. You just put a catheter with a hole in the middle of it into their bladder, and anytime there's fluid that starts to accumulate and gets to the level of that hole, it's going to drain out. A Penrose drain is an example of a passive drain. And then you have your suction drain. This is your active drain. It has to have some kind of suction, right? Your hemovac drains, your water-sealed chest drainage system is a suction drain because you have to hook it up to suction. These are your chest tubes. Right? And then your stoma pouch, these are for like colostomies and things like that. That's the bag, like your colostomy bag that goes over the top of that. And that would be considered like passive because there's no suction associated. You don't have anything in there that is actively suctioning the stool from that stoma. Wound dressings. I think I'm going to save that for the next time, for Friday. Remember, guys, assignments are due on a weekly basis now. Your first post in your discussion boards must be done by Tuesday night. I no longer have control. I cannot go back and open up anything for you. If you do not put in your initial post on Tuesday, then you cannot do responses because you can't access it anymore. So if you don't put in your initial response on Tuesday, it's a 0 for your discussion board for that week. Please, I sent you all the time management tool. Take some time, sit down, map out your schedule for the week. Put in everything from the time you get up to this, how long it takes me to shower, go here, go there, do this, do that, whatever it is. But this is when I have to work. These are the days. These are my hours. This is, when, this is me in lab. These are the times I got to be in lecture, right? These are the places in the areas that I got to do. This is what I got to be. Then look at those places where you have empty time, where you don't have something scheduled in, and put, something for school in there and do it day by day. Okay. On Mondays, I got no time. On Tuesdays, I got no time. Okay. I know I have an assignment due on Tuesday. Let me look back. What do I got doing? What do I got going on Sunday? What do I got going on Saturday? Do I have 30 minutes in here somewhere out of these 4 days to knock out this discussion board? And even if you just put in your initial post, if that's all you've got time for, fine, but you've got to get that in by Tuesday night. Because then if you don't, then that negates you for the rest of the discussion board. And then you'd have to find some time between Wednesday and Friday to do your 2 responses. All right, guys. Like I said, I'll be. Let me check to see if these access codes have been put in, and I can give you the access code to the quiz for this week. Oh, yes. Let me see. I'm not seeing anything yet. So it looks like there is no access code yet for the quiz for this week. If you find something different, if you go to get into the quiz and it tells you to enter an access code, please let me know immediately so that I may get that code and get you guys taken care of. All right, you guys have a good rest of your day. Hope to see you guys tomorrow in lab. And make sure we're working on our EALs, chapter 21. And I believe you have like chapters 4 and 6 open. If you have multiple chapters open, uh, as long as they're open for you, just keep working on them. Just keep working on them. I'm not going to go and report to them, hey, they got these ones open when they're not supposed to. No. If you got them open, work on them. If you're having a problem and they're not opening for you, I need to know that immediately too, so that I can get a hold of somebody and get that corrected as soon as possible. Um, as we go through this transition, I'm sorry that you guys have to be the guinea pig for a lot of things, but um, it's good practice for surgical techs because we're very adaptable people. So thank you guys for hanging in there with us, and uh, before you know it, it'll be November, and you'll be out in the real world. But all right, like I said, you guys have a good rest of your day, and we will see you later.